Great. Good evening, everybody. Thank you so much for returning if you've been to the first two webinars, and welcome if you're a new joiner for the third. Claire and I both work with the Child and Adolescent Health Service, and these are our priorities and values. So we always ensure that our work and our teaching is in line with the CAS values. In webinars 1 and 2, we spoke about a case, the identification and diagnosis of ADHD, the role of the GP in shared care for ADHD, and particularly stimulant medicine prescribing. And we've also spoken about common non-medication strategies and common co-occurring conditions with ADHD. So we've really provided quite a broad overview. So this evening, again, we have quite a short webinar, and I will always stress that this doesn't replace comprehensive training packages that are available for GPs, both on the RSCGP website currently and also in development in terms of increasing skill sets for interested GPs. I always want to stress as well that GPs have a really wide skill set and manage many more conditions than specialists do, and you guys do that both safely and well. And so our aims for this section are to outline the commonly used medications for ADHD, the common adverse effects, and the more complex adverse effects, which might require referral back for a specialist review. So reintroducing everybody to our case study, Danny, we met him 2 months ago now and reviewed his journey with the Child Development Service and his transition to a shared care arrangement with his GP. For those who didn't attend, briefly going through Danny's story, so he had his first assessment in the paediatric clinic at age 4 due to early concerns with language delay and some differences in his social skills. Subsequently, he had further assessment at age 6, having been referred back by his social worker, and there were concerns that were more in keeping with possible ADHD. So concerns regarding his attention, his memory, his organisation, so both factors of executive function, hyperactive behaviour, and ongoing issues with his emotional regulation. And this was occurring in the context of a family history of ADHD. He was confirmed as having a diagnosis of ADHD combined subtype about a month later, and then following stabilization on medication and ensuring his eligibility for shared care, this was recommended when he was 8. In the second webinar, we started talking about some complications. So at 9, Danny was starting to present with some features of anxiousness, so regularly refusing to go to school and becoming more upset with separation and sleeping back in her bed, but also some learning issues, which are commonly co-occurring with ADHD. So reading, writing, and some emotional regulation difficulties. So with that, we talked a little bit about common co-occurring conditions and also some non-pharmacological treatments. So in summary, really for the last webinar, this summarizes the non-pharmacological treatments as per the AADPA clinical practice guidelines. We've spoken about those a little bit, but the Australasian ADHD Professionals Association have released clinical practice guidelines and prescribing guidelines. And so this is one of the fact sheets that are available on their website, and I've published those in the resources. We spoke about lifestyle changes such as sleep support, screen time, parent mental health, and family function. So for our third webinar, we're talking about Danny now at nearly 12. So he's in year 6 at primary school. His medication is taken consistently, but his teacher started saying that it doesn't really seem to be working. And when it is working, it seems to wear off pretty quickly. So the family come to see the GP for a scheduled review, and at a recent meeting, the class teacher asked that question directly. She has fed back that settled for about 2 hours, and then also in terms of logistics, he's forgetting to go up to the office at lunchtime for his dose. Danny's finding the afternoons difficult. He's becoming more oppositional for tasks and activities that didn't really used to be a problem. And importantly, he's going to high school next year. And so we're starting to think about how we're going to manage medication administration next year. So this will always be a hot topic, and I always want to really reiterate that this is a very broad skip through the commonly prescribed medications for ADHD. There is a wonderful CPD resource on the RSCGP website that's been put together about medications. There's good resources on the clinician assist guideline, and so this is really just an introduction for the medicines that are used commonly in Australia and also just to have some memorable takeaway points for them. But if you are interested, please do go ahead and look at some more. So this slide was in webinar 1, and we touched upon the commonly used medications for ADHD. So we'll talk about each of these options. So again, we talked about immediate release and long-acting stimulant medicine, thinking about other types of stimulant medicine, and then third line, when we've had a really good crack with stimulant medicines, we think about non-stimulants. So there is solid evidence for medication use for treatment of the symptoms of ADHD, and actually medication use and the options for treatment haven't really changed dramatically over the last 15 to 20 years. So it's been consistently shown in meta-analysis that medicine does provide a clinically important benefit in the management of symptoms. But again, going back to the essence of ADHD as a neurodevelopmental condition, it is not a cure. And so in studies looking at the long-term benefits of medication, that it's not something that makes ADHD go away, but it often improves function, particularly with the core symptoms. And there are some studies to back that up. A very well done study back in the 90s called the MTA study looked at medication as compared to non-medication strategies. And really it does have an edge for the core symptoms. But as we talked about in webinar 2, non-medication strategies are so very vital for family function, for day-to-day life, and learning those strategies to manage your own neurodivergent mind. So again, this is taken from one of the resources available from the AADPA website, and is quite a clear flowchart for the pharmacological treatment for ADHD. So you can see quite clearly the first line is one of the 3 types of stimulant, which I'll talk about later. Second line is one of the non-stimulants. And interestingly, they've also placed in third line and fourth line, which I'm not going to talk about today because really for pediatric ADHD, we really stick to those top 2 lines. And so I've blanked those out. And today we're going to talk about the types of stimulant and then briefly talk about atomoxetine and guanfacine. So I've popped the box on the right-hand side for some of the drug names that you might have heard of. So Ritalin, Artige, Concerta, Ritalin LA, and Vyvanse. There are many, many scientific papers and lots of detailed explanations about how the medications actually work. But what I'm going to do is I'm going to use the language that I use with families, which will hopefully make it more memorable. So I describe an area of the brain called the prefrontal cortex, and I tell kids that it's a little bit like the boss of their brain, which signals to the other areas of the brain when we need to pay more attention, we need to regulate staying still, kind of regulating our impulses. And I always stress to kids that the prefrontal cortex in infancy and preschool years is relatively small and inactive. And so we don't have the same expectations of a 2-year-old to sit still and do their maths homework as we do of a 6-year-old, a 10-year-old, or a 25-year-old. And I really reinforce to kids that their prefrontal cortex isn't fully mature till 25, and make a joke about how teenagers still do impulsive things. So essentially what medicines do is they act to enhance effective messaging by making the neurotransmitters dopamine and noradrenaline more available. So by stimulating dopamine, it essentially produces a decrease of noise, and so decreasing those sensory inputs or those messages that are not primary or important, and enhancing noradrenaline transmission, which strengthens the appropriate connections. So again, you can nerd out on all the pharmacology and all the different ways that it works, but realistically, this is the way that's memorable for families to understand that there is real science behind why medicines work. There's also an upside down U-shaped curve for effectiveness, and so an optimal dose does need to be found. And so what I say to families again when we start medicine is that we're going for the lowest dose that gives the best effect with the fewest side effects. Again, on the right-hand side of the slide, I've popped some more ways that the medicines work. But again, it really is all around the movement of dopamine and noradrenaline. So stimulant medicines are actually among one of the most studied groups of medicines in pediatrics, and they've got really good effect sizes. So we can see that 70% of individuals respond to one class of stimulant, 70% respond to a different type of stimulant. So overall, we get really good responses in some way to some form of stimulant. And there's actually no real clear evidence for choosing one over the other. The AADPA guidelines don't preference one, whereas the NICE guidelines over in the UK do recommend methylphenidate, known as Ritalin, as first line. So essentially, we have a chat to the family about how we take a stepwise approach, but we might also be guided by duration of effect if we're starting medication in an older child. In practice, if there's a partial or inadequate response to one stimulant, then we do often try another stimulant, unless there's a real medical reason or a severe adverse effect, which would mean that we would be a bit more cautious. So the three stimulants that we use are either methylphenidate, dexamphetamine, or lisdexamfetamine. Again, going back to what I talked to families about, this is the really simplified graph that I use to explain the mode and duration of action of the stimulant medicines, and that includes the time of day that it's not effective and the timing that it's most effective, and also the timing of the most common side effects. So I say to them, when kids wake up, their brain is their brain. It's often very busy, it's often very active. We get some food in our tummies at breakfast, we have our first dose of medicine, and in about half an hour, so by the time we're getting to school, that's when we're hoping to see medicine working in the unique way that it works for that child. But interestingly, when it's in that very high-tech star zone, the most common adverse effect is appetite suppression. And we'll also notice that the second dose of short-acting medicine is wearing off kind of mid to late afternoon. And so just for families to expect that actually the time outside of school hours still requires all those other non-medication strategies. The other thing I mentioned is around this other common adverse effect of medicine, which is delay in sleep onset. And kids are sensitive to stimulants in different ways. One way I described it to kids in clinic just today is that there's some adults that can have a cup of coffee at 8 o'clock and still fall asleep just fine as a stimulant. And then there's other people that will have a coffee after midday and not be able to sleep. The most common, well, when they've done a big population or big cohort study, the common extra amount of time that it takes to fall asleep is 10 minutes. So some kids are not affected at all, and other kids are greatly affected. So it's something that we always talk about with families. So for younger children, we're aiming for about 8 hours of duration of action. And so they're often commonly started on short-acting preparation so that we can really kind of adjust and titrate that dose, but given once in the morning with breakfast and once at lunch and often at school. For older children and adolescents, often they need longer duration of action to cover school and after school activities and homework, and also because their bedtime's a bit later. So that's either 3 times a day dosing with short acting or using one of the long acting preparations. So these graphs have been taken from online sources, but I've adapted them with a little pink arrow, and that along the x-axis shows when a dose of short acting would be given. So it's comparing on a pharmacokinetic dynamic, I can't remember from my exams, but the different ways that short acting and long acting work. So on the left is Concerta, which is a form of long acting methylphenidate, which has a duration of action of up to 12 hours. And with Concerta, about 12.5% of the total dose is provided in the first 4 hours as immediate release, and then it's released a slow release over the subsequent 8 hours, so 12 hours altogether. Whereas on the right is Ritalin LA. And so 50% of the dose is delivered as immediate release in the first 4 hours and 50% in the second. So that's got a total duration of 8 hours. And with lisdexamfetamine, that what you can see is one dose of dex as compared to one dose of Lisdex. So lisdexamfetamine is an inactive prodrug of dexamphetamine. So it's essentially dex combined to a lysine molecule. So that's absorbed and then it's hydrolyzed into its two parts, so lysine and active dexamphetamine. And so because of that kind of link between lysine and dex, it means it's protected from the first path. Kim, I'm going to answer questions at the end, so if you can just hold on to your questions for now, thanks. Protected from metabolism the first time it goes through the liver. And so it can take a little bit longer to become effective because of that, but then the duration of effect is much longer. So there's a small number of absolute contraindications to the use of stimulants, and most of them are not really seen in our pediatric population, but I've popped them down on the left there. So things like glaucoma, hypothyroidism, using other medications like, I won't pronounce that without stumbling, pheochromocytoma, or a history of psychosis or bipolar disorder. But one thing we do think about are cardiac risk factors. It's actually been shown that ECG is not routinely required before starting medication, but we take a history and we consider it because we think about things that might increase kids' cardiac risk. So things like congenital heart disease, if there's sudden death in a first degree relative under 40, if there's kind of cardiac symptoms, so shortness of breath or fainting exertion that isn't a more common adolescent or child cause of syncope, which is often things like dehydration or being a bit overwhelmed. If they have palpitations, and particularly if there's a family history of arrhythmia and thinking about the genetic causes and things like long QT. So if there are any of those, we will always ask for an ECG plus or minus a cardiology review if we are concerned. Very briefly, there are two principal non-stimulant medicines that are used in Australia for the management of ADHD in kids. The pharmacodynamics are much more complex, but with regards to effectiveness, they're considered effective in about 4 to 6 out of 10. So it's a bit 50-50. It is important that they are started by a specialist, so by a pediatrician or a psychiatrist, and the PBS actually sets that out. So we can't give future prescriptions by a non-specialist unless the first one's been prescribed by a specialist. And so they're considered when stimulants are contraindicated for medical reasons, if stimulants really aren't tolerated, if there's been a comorbid mood disorder that's been caused by the stimulants or made significantly worse. And there are some families that really have an aversion to even trying stimulants, and after giving them informed consent about safety and about effectiveness, and they're still not keen, then that's where we would consider non-stimulants. And also to be important as compared to stimulants, there's quite a low abuse potential for these. So atomoxetine is dosed by weight. It started at 0.5 milligrams a kilogram a day for a week and then increased up to 1.2 milligrams a kilogram. And the most common side effect is nausea. It's very much a gastric irritant, and a lot of kids I've had to stop this because they just can't tolerate it. Whereas guanfacine is the newest kid on the block. It was made available on the PBS in Australia in 2018. So that started at a dose of 1 milligram once daily and increased. The maximum dose in young people less than 13 is 4 milligrams, and for adolescents and adults above 13, the maximum dose is 7 milligrams. Both of these aren't an immediate showing that we can work like the stimulants are. So atomoxetine, you really have to bed down for 3 months of taking it consistently every day before you decide whether it's going to be effective. And in Tuniv, slightly less time, but still you do have to confirm to families that this is not just a taking during the week. That's okay. Taking during the week and stopping at the weekend, you have to take it every single day. So Claire is now going to talk about some of the medication issues that can be managed and chatted about in primary care.
Thanks, Fiona. Okay, so just a quick refresher about sort of prescribing criteria for GPs, and the paediatric cohort must be reviewed by the approved specialist every 12 months. So noting that in ADHD, really the only two approved specialists are psychiatrists and paediatricians. The prescribing must be part of a shared care model, so there must be some reviews as mentioned. In adults, that's every 3 years with the approved specialist, but 12 months for paediatric. And the approved specialist can actually withdraw from the shared care model, but according to the Monitored Medicines Code, that must be in writing. In WA, our code states that anyone who's not an approved specialist, so that includes GPs and nurse practitioners, we're not permitted at this stage to initiate an S8 stimulant medication or alter the stimulant dose without written authority. And we're not currently permitted to prescribe an S8 stimulant medication if they have an authority on Script Check WA, and not allowed currently to alter the S8 stimulant type or formulation. This is a hark back to the first webinar as well. So just a brief overview. Some of these I'll go into more detail, but essentially just to be mindful that the side effects of stimulants of headache and abdominal pain are usually transient, and tolerance to those symptoms often does develop. So if you're getting a child coming in with that after a stimulant has been either initiated or increased, then it is likely that that side effect will subside. Seizures can also be quite, or the worry about seizures can be quite topical with parents, but there is no current evidence that there's an increased risk for continuation of treatment. Behavioural difficulties, are common, but the very extremes of behaviour really do need to be re-reviewed by the approved specialists, and medication either changes or reviews made as necessary. And if necessary, so if there is sort of an intolerable side effect, stimulant medications can be safely reduced or stopped until discussion with the approved specialist. But non-stimulant medications such as atomoxetine, which is like an SSRI type medication, does need to be tapered, and guanfacine needs to be tapered because it can cause a rebound hypertension. So as Ronna mentioned, appetite suppression is really common with stimulant medications, and sometimes this is what it can lead to faltering growth or even weight loss. In the primary care setting, if the growth velocity slows, so either there's static growth or the child drops 1 centile on a standard growth chart, then it would be important to increase the frequency of reviews, potentially to 3 monthly, and introduce some kind of dietary changes. And so that might include taking the medication either with or after food rather than before meals, because as Rona mentioned, if it gets into that kind of star area, then the appetite really isn't there for the child. Having a main meal for breakfast, so quite a lot of buffing up your main meals, your breakfast with proteins and things. Supplementing the diet with low volume but high calorie foods, so nuts and trail mixes and avocados and things like that is really important. Sometimes you need additional meals and snacks at the times when the medication really has worn off. So either really early in the morning before it's kicked in, or later in the evening when it has been worn off. So, reintroducing an old school supper is not a bad idea. Obtaining dietary advice, so sometimes formal dietary advice might be what a family needs from a pediatric dietitian, and as mentioned in webinar 2, could consider a chronic condition management plan for that. And then taking a planned break from treatment, or it's otherwise known as a drug holiday. So sometimes when it's less important that a child has that kind of focus and concentration, such as on a weekend or during school holidays, then taking a break for the medication can increase the appetite enough that weight loss is no longer as much of a problem. And just to say that that can be done safely with stimulants, but not with non-stimulant medication. So if it becomes more complex, the child either crosses 2 centiles on the standard growth chart, then really you need to be re-reviewed by the treating paediatrician, in addition to enacting those dietary measures. And for obviously we all know about access issues to the paediatrician, so sometimes providing a short-term script of about a month to allow that appointment to occur is worthwhile. Sleep is a big issue for a lot of children, but particularly for children on stimulants. I just put the sleep needs up there in the corner as a reference, and obviously different children are different, but this is kind of the average times that they might need. So really with parents, and this going back to basics is really important, and kind of setting the child up for success in sleep is really important. So a sleep schedule means that you're trying to go to the same bedtime every night, even on the weekends. Establishing and keeping to a bedtime routine. Using strategies to help the child wind down at night. So busy children often need time to relax. So things like, calming music or meditation or reading to them can be important around this time. Ensuring a bedroom suitable for sleep. So is it quiet and dark enough, or if they do have a kind of fear of the dark or anxiety around that, is there a suitable night light? I'm trying to avoid kind of blue light situations. Like Brona said, avoiding caffeine. If they're really having trouble sleeping, then you're probably going to err on the side of not using caffeine in the afternoons. So that includes kind of tea, coffee, chocolate, sports drinks, and obviously stimulant drinks. And turning off the technology at the moment, the guidelines would suggest an hour before bedtime. So that's screens of all types, phones, tablets, TVs, etc. There is some evidence in insomnia for cognitive behavioral therapy, specifically for insomnia, although that evidence really is probably more in the older adolescent adult cohort. Young children really aren't as able to kind of do those kind of cognitive behavioral techniques. But if that is something that the family wanted to explore an older child, they may well be eligible for a mental health care plan to access that. There isn't any at the moment, as far as I know, publicly available CBTI. And so it would be private, which is obviously a barrier for some people. And then in terms of specific medications for sleep, melatonin is very topical. And as Rena mentioned, it's a sleep initiation that is usually the difficulty. And so a immediate release melatonin, which would be on private script, while you enact all the other sleep hygiene measures to try and get a good sleep routine, would be something you can consider. Again, access is an issue. It's usually compounded and can be quite expensive from pharmacies. There are other concerns with sleep, like potentially other difficulties, like maybe a periodic limb disorder, periodic sleep movement disorder, limb movement disorder, sorry. Then there is some evidence for actually buffering up the iron, and obviously iron deficiency in children is quite common. So, and restless sleep as a result of iron deficiency can be quite common. So supplementing with ferritin might be worthwhile to try. The final thing to say is obviously if the sleep is an ongoing issue and is more complex than this, then maybe a medication review with the dose or type of medication would be important with the approved specialist. Moving on to cardiovascular side effects. So hypertension is a common, or not common, but is a side effect that is known from stimulant medication. And so it's important to monitor the blood pressure with an appropriate sized cuff. Child Development Service quotes sort of a 90th centile, although there's a little bit of difference in guidelines. So the AADPA guidelines might say 95th centile, and that's according to age and height. And there's growth parameter charts that are available, freely available. And really would have to be not a one-off measurement, as we would know, but a repeat measurement, and then requesting paediatrician review as a result of that. Sometimes, you know, as we all know, in general practice, doing it outside of the clinic setting, doing a blood pressure outside the clinic setting can give you like a more accurate kind of reading of what their baseline blood pressure actually is. And in some cases, you might need a 24-hour blood pressure monitor. But if there is persistent hypertension, then a dose reduction or ceasing the medication might have to be part of the plan, and monitoring for resolution of that hypertension to prove that it was actually a stimulant side effect. If, however, there is an arrhythmia, then that is generally you would cease the stimulant immediately and refer back to the approved specialist. So again, the phenomenon of rebound is really the re-emergence of symptoms or mood, cognition, behavioural issues when the medication starts to wear off. And the time that happens really depends on the timing of the medication. And short-acting medication, it might happen in the late morning, which is why you're trying to avoid that by taking a second dose before that happens. The long-acting tends to be then in the late afternoon or early evening. So really just parental awareness or family awareness that this is a phenomenon that does happen, and then putting in place sort of scaffolding the family for what can be done. Mid-afternoon snacks can be important to prevent what is really hypoglycemia if the child has had, you know, an adequate dose of stimulant medication to focus and concentrate while they're at school, but they haven't really eaten much lunch or anything really since before breakfast, then that can be important. Exercise, so, you know, getting their sillies out essentially in the afternoon can be really important at this time. And then some children will respond to different types of relaxation techniques as well. but just really creating a lower stimulus environment. In terms of medication, things that can be offered regarding this rebound kind of effect, it might be that the approved specialist would think about extending the medication duration, especially as Rhoda mentioned, in sort of in the teenagers where actually they need it to last that time and they can't be significantly unfocused during like a homework period. And occasionally a second medication, such as guanfacine, which does have a 24-hour action, can be added really to avoid the real peaks and troughs of the stimulant kind of medication. And with that sort of added complexity of rebound, I'm going to throw back to Rona for some other complex challenges with medications.
All right, thank you, Claire. So medication misuse and diversion is always a really common concern, and in pediatric practice, it comes to our attention relatively rarely, but we do have to remember that Schedule 8 drugs are considered drugs of abuse or dependence. And interestingly, just as I was writing this talk, there was a meta-analysis published this year of 12 cross-sectional surveys, and they found that more than 1 in 5 people report misuse of their prescribed stimulants, and 1 in 6 divert them. So again, I didn't kind of go in and look at the nuts and bolts of the different studies, and I would hope that this is kind of an older age group, so adolescents and adults. But we do have to think about them. So risk factors for misuse include being prescribed an amphetamine-based stimulant, and also if people are already reporting a comorbid mental health symptom. And so a risk factor that they found in this meta-analysis was exposure to peers who were misusing their medication. And I have got the reference if anybody's super keen, and I can email that to you. So we, as prescribers, consider the risk factors that can be clear before prescribing. And so in the Monitored Medicines Code, it actually says the patient and family doesn't have a history of substance abuse, diversion, or misuse of drugs of addiction. Again, that can be sometimes hard to really properly quantify, but we do have a sense from our history taking and from family discussions about that. When we're prescribing, we always ensure that there's a minimum script interval, and that's actually mandatory here in WA, but that prevents individuals having a surplus of medication. We use available programs, and so this is where Script Check WA is incredibly important, and this is to ensure families are not obtaining medication from multiple sources. So I say even though using Script Check WA is a recommendation in the Monitored Medicines Code, I would say that it's mandatory. It's really important to check just before you prescribe whether, number one, the kids are due to have a new script, but also kind of when families have been picking up medicine, because if they've been consistently picking up early or being a little bit less consistent, then that can be unusual. There are some kids where we would consider doing a urine drug screen for the child, because if they don't have any stimulants in their system, then you can be a bit more concerned that the medicine's not going to the person it's meant to be going to. So these are a few things that can pop up, and this happens to me in pediatric clinics. So they can purely represent a parent with undiagnosed ADHD who isn't able to kind of keep up with where the medicine is. So things like I've lost a few tablets can have a new script, so they can't account for all of the medicine. Quite commonly people, and obviously I work in some lower SES areas, but lots of cars are broken into and the medicine stolen. But if that's the case, then often we have to ask for a police report before we'll prescribe any more. And then we do have a lot of separated parents and kind of blended families. So if medication is in different locations, then often individuals might have less. But again, that's something that we have to reinforce, that you just have to keep account of where all the medicine is. And once or twice, it seems to be okay. But if it happens really frequently, then that's when our alarm bells start to ring. So if you are concerned, some common strategies are listed here. So for some families, I might limit prescribing to just 1 bottle or box at a time. Another thought would be if we're concerned about their misuse of short-acting medicine, then changing them to a longer-acting formulation that has a much lower potential for abuse. There are some kids where we organise for medicines to be dispensed at school only and not in the home. And there are some families where we will actually stop medication, and there's a way of putting a hold on the prescription on the Proto website. It is really important that you keep track of growth for kids on stimulants. So during GP review appointments for shared care, it is really important that we check weight, height, and blood pressure. Families might be resistant to changes in medication if it's working really well, but I do reinforce to families that kids essentially need to grow and they essentially need to sleep. Um, Transient weight loss is really common, but if it doesn't improve with the strategies suggested by Claire, particularly after kids have been stabilized on medicine for a couple of months, then we do have to think about going back to the specialist and thinking about alternatives. So even on this graph, you can see that the weight started in the 90th centile before starting medicine, but it's been static over quite a long period of time. So, and it's now sitting on the 25th centile. So when you look at BMI, it looks quite dramatic. So again, just to reinforce, if there's sustained weight loss or poor weight gain causing crossing of centiles, it requires review. And interestingly, sometimes a change of medication, even just to another form of stimulant, can have a really different side effect profile. And I had that in clinic today. One child had really depressed appetite on Vyvanse and did much better on Ritalin, and the next person through the door had the complete opposite. So it's important to know that each individual will have individual responses to medication, but we really need to keep on top of weight loss, even when families are desperate to keep going. Another scenario is where the positive effects of the medicine are good, but the adverse effects are really impacting on quality of life. And this is often the mood and behavioral side effects. So kids, particularly if they were prone to anxiousness, might have increased anxiety, as we talked in the last webinar. There might be increased agitation and aggression. Their sleep onset just must be, it's sustained, is persistently bad, persistent poor appetite. And if the symptoms in the afternoon are really tricky, so we just have to consider the different types of medicine that are used, the profile effect of each of them, and that really changing the dose or the formulation might be the response to this. So additionally, although stimulant medicine is dosed by effect rather than age or weight, symptom control can actually change as kids get older and bigger. And so that kind of story would be where medicine did seem to be effective, but now it doesn't seem to be working quite as well. And so the symptoms that were previously managed are starting to creep back in. So finally, the practical aspects of taking medication are important, particularly for kids at school, when the schools are relying on the children to remember to go up to the office. And I normally reflect back that it's useful for the grown-ups to be able to remember it too, rather than relying on a small child with ADHD. But also some of the older kids in primary school and particularly in high school really don't want to be one of those kids that goes up to the office. We're trying to reduce the stigma of neurodivergent minds, but kids just want to go out and play. So there's some kids that will start avoiding going to take it, and some adolescents just want more flexibility. So going back to our case study, we were looking at what Danny was kind of presenting with at nearly 12, and the issues that came out of that were that his medicine effectiveness had gone down, his compliance with taking it consistently had gone down, and that he was experiencing some symptoms of his ADHD that felt quite hard to manage in the afternoon. So our responses would be a medication review with his specialist. And for Danny, I would have a look at the dose of medicine that's being used, but also whether the formulation is appropriate for him and consider a long acting. And again, with every opportunity to reinforce that ADHD and neurodevelopmental conditions are a lifelong difference that will have different effects on function at different times. But it's really understanding for Danny himself going into high school, what are the best ways that we can help the symptoms with medicine, but also look at the best ways that he learns, the best way that he makes friends, and the best way that he can manage his own mind and body. So since the last webinar was since we were here, I've got a few different resources. So this has always been here, but I know that a lot of GP feedback has been about contacting the pediatrician and how hard that can be. And one of my roles is really looking at different messaging systems and looking at places in other areas of Australia that are doing that successfully with GPs. But in the meantime, I really want to reinforce that on all correspondence that GPs receive from the Child Development Service, so clarifying that this is in the metro area, there is an email address on all of those letters for each centre, and there's a named paediatrician on each of those. So there is a way of reaching out to the centres if you would like to seek some advice or seek a follow-up appointment for a child. And if not, it's you can click on that link and that will give you a list of all the centre locations and contact numbers. In my role, I am available for education about shared care and support and directing people to the child's managing paediatrician. So that's my email address. And there's obviously information about ADHD in children and youth that we've been talking about the whole way through. That is on Clinician Assist. So that is the talky part of the presentation, but we did make sure that we had time for questions and we've got a good 20 minutes. So I am really happy to field some questions. I think Michelle's got a couple of extra slides and then we can crack on.
Thank you. So I'm just going to start reading out some of the questions from the chat. And if you could speak to those, that would be great. So a lot of shared care co-prescribing happens earlier than your examples. Could you please comment on the city versus country, perhaps?
Tricky, because Kim, I don't work in wax, and so I only know, I guess, from hearsay and from colleagues that have been working in wax, but I know that accessing consistent pediatric kind of communication responses can be much trickier. I think shared care, this is a speculation, but shared care has probably started a wee bit earlier for country kids just because of the timing of the pediatrician being able to come out to visit site. And so it might be kind of put in place earlier so that GPs can hold in community until the next visit by the pediatrician. But again, I can't say directly. I do have contacts within WACS, but I haven't been able to kind of sort out their shared care just yet. The next question I can see is about off-label clonidine. It's a tricky one because as an ADHD treatment, it's not that great. And it's certainly not held up as one of the ones that we would try, but I am totally aware that in desperation, there are people outside of being stimulant prescribers where they want to try something. The NICE guidelines in the UK say no clonidine for ADHD ever. In Australia, we are a little bit more kind of circumspect, but clonidine essentially is quite a blunt instrument and it's essentially for hyperarousal. And it's not necessarily something that's specific for ADHD symptoms, but can certainly, if kids are really heightened, then it can settle things down. But obviously, the most common side effect of that is drowsiness. And so, in some ways, sedating kids and turning down the volume on their ADHD symptoms is not ideal. And a lot of kids say it actually makes them feel a bit gross. But as a holder, there are some kids that I have kind of reluctantly done it. With regards a patch, like a clonidine patch, I haven't gone and looked at literature around whether that's been studied for ADHD. I think clonidine patches are available, and Claire might be able to answer that, but certainly in the hospital setting and not necessarily in community peds. Claire, are you available of aware of clonidine patches?
More in the hospital setting and more for
Chronic pain and things.
and blood pressure as well sometimes.
Yeah. And Kim, one final thing that you mentioned while I was talking about stimulants was a small dose at bedtime. And I remember Trevor Parry talking about that. So, and it's in the prescribing guidelines, which I was going to mention in a second. But there is, I don't know, evidence-wise, but in clinical practice, there are some kids where half a tablet, like 5 milligrams of methylphenidate, helps to settle things enough to be able to get to sleep and kind of calm the real busybodiness of it. But if it doesn't work, we're not surprised. So if it is something that we do try, then we would recommend trying it at the weekend or during school holidays, where if it ends up meaning that they don't get to sleep at all, at least you can cope the next day. So yeah, what I will, just while people are still thinking of questions, the ADPA has recently produced and made available a prescribing guide specifically for prescribing in primary care, prescribing as part of shared care, and it is a free ebook that's available to download from their website, so you don't even need to pay for it. I've had a look through because I've got the original prescribing guide for specialists, and it's all the most useful information, but just to distill down into the scenarios that GPs would need it for. And it's a lovely combination of both evidence, but also clinical practice from specialists. And they've always made sure that they've had lived experience. And so there are comments from individuals with ADHD talking about what medication and medication changes feel like. So I think it's a good resource that I would be really keen for everybody to start looking at and using. hopefully that answers your questions. I know that medicines is such a big thing, and I will make a small comment that the landscape is most likely going to change with more prescribers in primary care. And in some ways, I think that's a change that's happening not just in WA, but across Australia. So this webinar is kind of appropriate for the WA setting at the moment. And certainly working within the Child Development Service, we're really keen that all GPs, regardless of their level of interest, feel comfortable managing kids and straightforward issues in the community, but also ensuring that we improve our communication about the more complex kids.
Thank you, Dr. Rona. Does anyone have any more questions? We encourage you to keep putting them in the chat. I actually have a question. How do you differentiate between the side effects of the medication and other comorbidities such as anxiety or just emotional dysregulation? How do you tell?
It's really tricky because behavior is a hard thing to kind of categorically measure. Essentially, if there is something new that has happened since starting medication and you're unsure whether it's related to the medicine or whether it's not, again, because stimulant medicines are so safe to stop without having to wean them down, then you would have a trial period of not taking it and seeing if those symptoms resolve. So that would normally be my first step. But it does, I think that question does play into the complexity of behavioral presentations and neurodevelopmental presentations, that actually very rarely things go in a nice straight line. And so sometimes by treating ADHD symptoms, symptoms of other conditions become more prominent. So it's a journey that you go on with families and kids.
Thank you.
Okay.
Well, if there's no more questions, you do have the opportunity to ask any questions that you may. Oh, no, there's someone typing. Sorry, I jumped the gun.
That's okay. No, that's good. Yeah, so Naomi's just asked, do you find anxiety can often reduce due to improved clarity? I actually made a mention of this in the last webinar because anxiety in the context of ADHD can have different drivers. And so if the origin of your anxiousness is actually untreated ADHD, by treating the ADHD, your anxiety can get better. For some individuals, the side effects of the stimulants can exacerbate kind of underlying anxiousness and make it worse. And then there's some people that, regardless of medicine, actually they just have co-occurring anxiety, like an anxiety disorder that's separate to the ADHD. So yes, anxiety can get better. And so being anxious isn't necessarily a contraindication for trying stimulants, but you just caution the family that we need to watch for that. The next question was about a link for the blood pressure chart. We totally can. The other thing is, if you go to the clinician assist guidelines, there should be a link on there as well. But I'm sure we can publish it for you guys.
Thank you. Does anyone else have any more questions that they are thinking of? Yes.
Oh, we just got a thumbs up from Deanne. Thank you.
Thank you.
Combination short acting and long acting. Yes, we do. Again, it's moving a little bit away from the science and more towards the art of treatment, but what you're aiming for is symptom control that suits a young person. So short acting is sometimes used as a kind of top-up dose later in the day. So for example, if you took Ritalin LA and it's effective for 7 to 8 hours, but you still need a little bit of extra coverage in the afternoon, then you might use short acting then. And then there's other families where we actually give the long acting in the morning, but we actually give them a little bit of short acting as well, just so that we can get kind of quicker onset of action. So for example, if you're using Vyvanse and it takes up to an hour to start working, then you might use a short acting stimulant also at the same time, just to get some symptom control earlier. So in answer to that, yes, we do. But we do it. And the aim is to try and use the smallest number of medicines, but yeah, it's possible.
Just put the link in the chat, so that has for the blood pressure levels, boys and girls for age and height centiles.
Yeah.
Thank you, Dr. Claire.
Yeah, and Naomi, that is really interesting because, and this is me as well, like I always thought that Vyvanse or lisdexamfetamine was kind of the same family as Dex, and so we used them together, but actually they are considered different stimulants. And so there are some families where they would use Vyvanse during the day and then have methylphenidate, and that's okay to do. However, we don't really use long-acting methylphenidate with short-acting Dex. That somehow I can't, I might misquote myself, but I think that's not allowed. Um, but traditionally, I think because we used to think that Dex and Listex were essentially the same thing, then we would use them both together. Blood pressure measuring on hyperactive kids. Oh, I mean, I do it every day, but it can be tricky. Um, I often find that actually doing a quick manual is much easier than kind of linking them up to um, the blood pressure. I can't remember the official name for it, but essentially just if I do it quickly with a manual and a stethoscope, I can get a reading much quicker, and that's often okay. I mean, depending what your background is, but I actually get kids to lie down and take some nice deep yoga breath, and that does tend to settle them. But yeah, as with all pediatric medicine, sometimes you have to be a bit creative. Don't jump too quick. Yeah. So often, if the kids have been racing around the room and then you do a blood pressure, then they could be super high because they're panting. So again, I get them to do some deep breaths and try and trigger their parasympathetic and calm them down. Because even if I get a really high measure to start with, we take some few nice big breaths and blow out balloons and candles and things, and often it can drop by a good 10 or 20. So definitely allowing for white coat. And if it's consistently high, just like Claire said, I'll get them to have it taken out in like a local pharmacy or at the GP. And that usually shows that they're less scary than I am.
Thank you.
It's okay.
I hope all of the questions were. If you have any other questions, we will have a QR code. And if you could submit your questions to us, we'll pass them through to Dr. Rona and Dr. Claire and then send them back out to you. But for now, we will wrap up. First, I just wanted to talk about clinician assist. So here are some screenshots of the pathway. As you can see, it's got some information about assessing children with possible ADHD, including some links to some of the screening tools. And there's also a section on the management of children while awaiting formal diagnosis, such as some non-pharmacological measures that can be started straight away. And then there's a section on management after formal diagnosis, covering medications used, prescribing regulations, and some of the monitoring recommended for children who may be prescribed stimulants. So if you're not already registered, this slide has all the details and the QR code for the website where you can register. And if you put in your APRA number, then your registration should be approved immediately. If you have any difficulties, please contact the team on the clinicianassist@wafa.org.au email address. And these slides will be emailed out as well, so you'll have a copy of them if you've missed the QR code. So if you could please leave us some feedback for the last ADHD webinar, that would be really great. And we thank you again for taking the time to come to this webinar. And we would like to extend our thanks to Dr. Rona and Dr. Claire, who've taken their time to share their knowledge with us today as well.